Welcome to our pre-conference 2025 ITUP. So we are so lucky to have all of you here today. I'm Crispin Delgado, Executive Director of Insure the Uninsured Project, ITUP. So welcome. I think the next one has a big picture of my face. That's me. You could scan the QR code that is on the screen right now. This will lead you to our program. You also, on the back of your badge, have a QR code in case you have to get the agenda at any time during the conference. Just a reminder of that. This year, we're also trying something new, and this is an effort for us to walk the talk. And, you know, this is for people that need translation and transcripts. They're available. If you scan the QR code on the screen, it will make all of our programming available in other languages. Let's get social. And so for this, we want to let people know that we would love for you to post on social media. And if you do, please use our hashtag ITUP2025. It would be great to see all of your beautiful faces on our feed. We just are launching also Instagram for that younger generation. You're welcome to use it. And as you saw out front by registration, we also have a background where you could have ITUP in the background. Next slide. So our thoughts are with the families and communities impacted by the devastating firestorm in Los Angeles. The loss and destruction have brought incredible hardship to a city we are honored to serve. During this tragic time, we extend our deepest sympathies to those affected. And for those of you that are interested in donating within the app, the event app, you will find a QR code to also connect to a trusted place to donate. So who are we? So ITUP is a 501c3 independent nonprofit health policy institute. For nearly, actually 3 decades, we've provided expert analysis and facilitated convenings of California health leaders around the state. ITUP focuses on workable policy solutions to expand access and improve healthcare in California. Our goal is to tell the story in accessible and easy to understand formats. Our values are that we seek a healthcare system that is universal so that all Californians are eligible for comprehensive health coverage and services, including primary and preventive health care services. Our system is equitable. Californians can expect fair access and treatment regardless of health status, age, income, language, race or ethnicity, gender, immigration status, and I'll repeat that one more time, immigration status, geographic region, and public or private coverage. We see a healthcare system that's accessible. Californians have access to coverage choices and services that are available, timely, and appropriate. We see a healthcare system that's effective. Healthcare and related support services are cost-effective, coordinated, and high quality. Lastly, affordability. Coverage and care should be affordable for public and private purchasers and for consumers at the point of care. So a little bit about how we do our work. You know, we see ourselves sort of in the middle, a bridge, if you will. Between the work happening with state leaders at the state level. So we help provide information and data to inform different policies and initiatives that are being developed. Where do we get that information? We work to empower regional leaders to inform health policy efforts. So every year we do 10 to 11 regional work groups around the state. We call them health equity collaboratives. And so This allows us to understand what is happening at the ground level, and we lift up those voices and share that information with our state leaders that are developing the plans, regulations, policies, etc. And so we see this as lifting up the voices of our community. ITUP greatly appreciates the monetary contribution of its sponsors and funders, which I will share in a little bit who they are. Without them, our signature events, such as this one, and publications would not be possible. As an independent nonprofit organization dedicated to improving the health of Californians, ITUP's views are our own. So let me talk a little bit about our core funders. So Insure the Uninsured project is generally funded by the following core support funders: California Healthcare Foundation, the California Endowment, and the California Wellness Foundation. And for this conference, we also thank our platinum sponsors, which include Kaiser Permanente and the California Healthcare Foundation. This would be possible without additional sponsors. So we see Anthem, Blue Cross, Sierra Health Foundation, HealthNet, Transform Health, Blue Shield of California, Promise Plan, as well as other funders. So thank you to all of them. A reminder to please put your phones on silent. I'm not asking you to put them away because, as you know, there's going to be QR codes available for folks. But I will mention, as you interact with the app, a lot of our publications and background materials are in the app. And so I would encourage you to, during the break, to look at it. Again, here is the Wi-Fi network as well as the password. And I will get to today's agenda. So as I mentioned, there's a QR code in the back of your name tag. And here you could scan the QR code to pull up the agenda. But I'm really glad to announce our first panel, which will be more in depth about what we know around the workforce and the time that, what is our call at the moment with our health workforce. I've mentioned in the past that, ITUP was a key contributor, was a champion for access to coverage. But now that people have a card, can they actually access care, right? And is that care equitable? Meaning, do their care teams look like them, speak their language? And so those are some of the topics that we're going to get into with this first half of the program. And then the second half will be looking more future-oriented. So we hope you stick around. That one will be more practical, and you'll be at tables working. So in 2024, ITUP held the regional equity collaboratives. We did the 11 in total throughout the state. As you can see on this map, we covered every part of the state from the far north to the borders of San Diego. And these included community champions, community-based organizations, Medi-Cal managed care plans, hospital and health clinics, county officials, as well as nonprofit organizations. The conversations focused on workforce challenges, and ITUP facilitated these conversations to do a deep dive to understand the workforce challenges and also the promising opportunities to secure a workforce reflective of the communities being served. Some takeaways from this work are that the first key theme was around economic inequality and resource scarcity significantly impact the workforce landscape. So this includes affordable housing, having limited career opportunities for spouses and partners, and exceeding staff capacity, and having insufficient wages and benefits. For this first point, I thought it was interesting when we talked to our friends in the far north, in the rural communities. They said that, recruiting providers, once one provider leaves, it impacts more than one community because a lot of people have to drive far distances to even access primary care. And as they're recruiting new people, one, you have to find people that are interested in living in rural communities. The second is, when housing is available, sometimes they can't get insurance, fire insurance. So that also creates an obstacle. And then lastly, finding work for their significant other. That has been seen as a challenge in recruiting and retaining folks. The second is challenges with integrating allied health professionals into traditional healthcare systems. So there's a lack of support for allied health professionals. So this could include community health workers and doulas, as they are included in CalNAME. We also see low reimbursement rates, and I know we've been hearing that for many years, but it's still a concern. And then as well as untapped reserves of doulas due to archaic requirements. And so this is important, right? As we're trying to promote the usage of doulas and community health workers, is there a place that people can go and find certified or trained people to be able to provide these services, especially in areas that are maternity ward deserts, right? We're seeing that more and more as hospitals close. Where can you access these services? And are doulas one additional element that can help bridge the maternal health access? Lastly, a third theme that we heard was around systemic barriers impeding utilization of data and technology. We still need improved accurate data collection and sharing. We also are finding challenges with digital literacy and broadband access. Those issues, those gaps are still prevalent in different parts of this state. And lastly, there's been setbacks in the data sharing agreements, understanding that not everyone is ready or able or committed to sharing their data. But the hope is that one day we get there. And I will throw in a plug for our closing plenary tomorrow, which is on data. And how do we tell the stories of our communities, but also how do we utilize data to advance equity? So with all of that said, it is my pleasure to introduce this panel, responding to California's workforce needs of today and tomorrow. So we're joined today by Dr. Sunita Mutha, the director, she's MD, FACP Director of Healthcare Center, Health Force Center at the University of California, San Francisco. And she's also the chair of ITUP. So she's my boss. Round of applause, please. Unfortunately, Eric is feeling under the weather, but luckily, we were able to invite Libby Abbott. She's the Deputy Director of Health Workforce Development at HCI. So welcome, Libby. Next, we have Cindy Sanchez, Senior Director of Policy and Government Affairs at the Community Health Association Inland Southern Region. So welcome, Cindy. And last but definitely not least is Alexis Taylor, Director of Transformation at Transform Health. Welcome, Alexis. And you guys know me already. So I am going to kick off this panel with an opening question. What barriers are you seeing that are impacting California's ability to recruit and retain a sustainable healthcare workforce? Would you like to start?
I'd be happy to. Can everybody hear me? No.
Should be up. No? Here, you can borrow this.
Okay, how's that? All right, off to a great start. Good afternoon, and glad to be here. Really looking forward to this discussion with this esteemed panel, and excited to be able to share kind of HCI's perspective on some of the challenges with health workforce development in the state. Particularly excited because it gives me an opportunity to talk about some work that we just completed and kind of share that with you all. So HCI recently conducted a strategy development process for our behavioral health workforce and our nursing workforce in California. And the goals of that exercise were to sort of do, as you described, to understand the scope and extent of workforce challenges across the state, and then identify the root causes and barriers that we need to address in order to solve those challenges. Our strategy work found a few common themes that we believe are important to address as we think about solutions in California. First and foremost for us was geographic maldistribution. Our strategy work was anchored in supply and demand modeling, which we conducted at the regional level and where the sample size was sufficient at the county level. So we were able to see for the first time which parts of the state face shortages for which roles and role types, very specifically. Notably, this is the first time we've done that within the state, and it's provided us with really invaluable and timely insights. For example, for registered nurses, we calculated a slight statewide shortage of about 2%, or about a 5,000 nurse gap in our most recent model. However, when we looked at the regional findings, we saw wide variation. So you mentioned the rural north earlier. In the northern and Sierra regions, for example, we estimate a gap of about 16% in the RN workforce, 12% in the San Joaquin Valley, and 7% in LA County. In other regions across the state, RN supply was more or less at parity with demand, and in one case we had a surplus. So really important to kind of understand the sub-state or more kind of regional picture. In behavioral health, our model found that all of the roles and all of the role groups that we examined are facing statewide shortages. Again, however, we saw the most severe shortages in the rural and northern Sierra regions, the San Joaquin Valley, and the Inland Empire. The San Joaquin Valley and Inland Empire, just to share some findings, are both missing more than half of the non-prescribing licensed clinicians that they need. So that's our LCSWs and psychologists. The northern and Sierra region has a 70% gap in psychiatrists currently. So they would need about 150 to 200 psychiatrists, we estimate, to meet current demand. So when you ask about, or talk about rural communities and ask about kind of where we're focusing our efforts, this data really supports the focus on rural communities and points to a very specific need to focus on the northern and Sierra regions and the San Joaquin Valley specifically. Another common theme that we saw was insufficient training capacity. So the regions facing the greatest shortages also have the thinnest infrastructure for training health professionals. And we know that that matters because people are more likely to work in the communities where they're from and the communities where they train. So we need those local training opportunities. In the northern and Sierra region, for example, we see fewer schools, fewer slots, fewer clinical training opportunities, which we know is critical, particularly for our nursing workforce. And we'd love to see more data, infrastructure, and cooperation and coordination on that topic. The list of barriers and drivers, I could go on and on. But that's part of what's challenging about workforce development for me is that the list is long and it cuts across sectors and players. So, for example, outside of the realm of workforce directly, we know that rural hospitals and clinics are facing sustainability challenges, and you mentioned this, are being forced to close or cut back available services because of financial instability issues. That then compounds the workforce issue as you described. So our findings really converge there. So kind of to zoom out, there's two major lenses that we're taking at HCI to try to understand and solve workforce challenges. The first is data. What do the data, quantitative and qualitative, tell us about challenges and potential solutions? This is really core to our approach, and we hope that with resources and bandwidth, we're going to be able to do more of this kind of work. We're hoping to build supply and demand models for primary care workforce, oral health workforce, and midwifery workforce to address birth equity. Number two is taking a holistic and intersectoral lens. We know that no single entity is going to solve this challenge alone. HCI has resources, but they're not enough to solve the problems, nor is our mandate broad enough to solve all of the root causes. We need our education partners, we need our employers on board, we need the folks that are here on the podium all to come together. So we're bringing these two kind of lenses together and hoping that we can, by generating actionable data and policy relevant data, create a framework that we collectively can use to kind of row in the same direction, move toward the same objectives, and really make a difference in workforce challenges.
Great, thank you so much. And you know, it's such a great reminder that we have to do this sort of at 3 levels at one time. So thinking about the short term and how do we fill vacant positions. In the middle term, thinking about how do we upskill the staff that we do have to keep them relevant, to keep them engaged in their work. And then in the long term, thinking about those pipeline programs and making sure that people from communities of color have access to those pipelines. Alexis, would you like to go next?
Yeah, definitely. I think that it's really important for me to call out that Transform Health. We really operate from this matrix perspective that you're calling out by really trying to identify these challenges, not just at the local, the state, and the national level, but also thinking about this across payments, across people, and across processes. And so when we think about it from this perspective, it really means that we have a multi-layered dynamic that we're trying to process. I want to call out one example specifically. At Transform Health, we have been charged by the Department of Healthcare Services, the state of California, that is administering CalLAME, that we are all so familiar with right now, as being one of the facilitators to really investigate challenges that are affecting CalAIM implementation. We have 3 goals in this role. Number 1, who are the stakeholders who are being impacted? Who needs to be a part of this conversation? Just as was mentioned, this is a cross-sector approach. Number 2, identify and investigate the challenges that organizations are facing. And number 3, really work to deploy solutions at the local, at the state, at the community-based organization, at the local and at the state level. So when we think about this framework that we're deploying, we are engaging our managed care partners, we are engaging the state, and we are engaging the organizations deploying these services. When we have aggregated all of this substantive feedback, we have learned that providers, in addition to not being able to identify workers and retain them, they are drowning in administrative burden. The redundancies of referrals, authorizations, and claims, trying to streamline processes when working with numerous managed care plans as they integrate social services into the healthcare landscape at a scale that has never been done before. So we are constantly reminding and encouraging these providers. They are pioneering these services, and as it pertains to that systems integration, the burnout that stems from that administrative burden is critical. And so some of the ways that we have worked to approach this is, number 1, working with DHCS, who has been a phenomenal partner in trying to streamline some of that administrative burden. Some of the successes that we have seen come out of that are referral standardization, making it so that providers can use one streamlined, standardized form, no matter the managed care partner that they are working with, because once again, this is integrating an entire allied workforce into a health system that they have never navigated before. Number 2, working with our managed care partners. Something that I think is often missing from this conversation is that the MCPs themselves were coming out of COVID and then transitioning into deploying a massive statewide equity initiative. And so they were experiencing a major whiplash trying to build new programming. And so we are partnering with our managed care partners as well, trying to ensure that they are also maintaining that internal capacity to work with the allied workforce, so that way we can reduce that administrative burden on both sides. Because what we saw was that the managed care plans and the community-based organizations, FQHCs, so on and so forth, trying to address health equity challenges, were spending so much time buried in paperwork that they were spending less time serving their communities. That is a significant barrier to the promises of health equity. And then lastly, another component of the burnout that we realize, which we don't think is discussed enough, is the compassion fatigue. It is very burdensome for providers to day in and day out try to navigate a health system that they have never navigated before, and aggregated with the fact that they are serving very vulnerable populations. And so we have seen the most retention with organizations that conduct internal case conferencing, checking caseloads, validating the fact that that fatigue is present, it's real, it's impacting their productivity, and then trying to work internally to toggle and offset and oscillate capacity across their internal teams. So once again, just to recap, we learned a lot about the administrative burden, the burnout, and the compassion fatigue, and are working with the providers themselves, aggregating data for DHCS, and going into our managed care partners to help them build processes that will allow them to work with an allied health workforce and therefore reduce that administrative burden so providers can serve more clients successfully.
Great. You gave us so many juicy nuggets of information. You know, and I also like to think of our allied workforce as a bridge to the outside world, right? That they are able to bring in the social context in which people are coming from and help address those needs. And, you know, your call out around leveraging technology even to address some of these burnout situations, right?
And I want to also add on top of that, that at Transform, in addition to being a matrixed environment, it is so important to reflect what you said, Crispin, to walk the walk. Yeah. We are also an organization comprised of individuals that come from the communities that we serve. And that's why me, being a long-term former Medicaid beneficiary, breast cancer survivor, and complex care patient, when we are working with managed care partners and with the community-based organizations, we know what it feels like to be the member that's stuck in that pipeline of trying to have your care coordinated and feeling the pain and the burden of being stuck in that system. So being able to support the workforce allows the work to move forward faster.
Great point. Sunita, would you like to step in, or we could also have Sandy? Sandy, will you go next, please?
Sure. I think I'd like to echo everything that everyone on here has said. I think geographic spread for the Inland Empire, or San Bernardino and Riverside counties, which is where our health centers are at, is enormous. I mean, you talk about having to drive somewhere. If you have to drive all the way to Needles, it is far. I've done that drive several times, and I can see how individuals, it's so hard to recruit individuals to go and work out there. So that has been a huge factor for our community health centers. I think in terms of pre-pandemic numbers, we still have not been able to staff clinics to what they were at that point. Turnover is just incredible at health centers, and this was, again, as a result of the pandemic and just individuals kind of being burnt out from the work that they were doing, or just retiring because of the time was coming to, and they thought that the risk was outweighed. So in terms of just the turnover itself, in 2023 it was about 25% for the community health centers, and then the year before that, it was somewhere in 30%, but that's huge compared to in 2020 when it was like 9.5%. So it's a huge increase and a huge jump. And then you take that and compound it with having to recruit someone and it taking you about 27 weeks to be able to find a primary care provider, about 23 weeks to find a nurse practitioner, to fill an MA spot, about 13 weeks to find someone. So you kind of take these numbers and you kind of crunch them, and being able to actually have, a fully staffed health center is, just been really difficult for a lot of our clinics, and ensuring that, like you all said, making sure that the community that's being served is being served by individuals that are coming from their communities and that understand it, is really important, because, you know, it is a very specific community. I feel like even just talking about the Inland Empire in itself, if you are talking to someone who lives in the high desert, it's very different if you're talking to someone who lives in San Bernardino, because specialty care is not necessarily all that accessible. Transportation is really difficult as well for individuals. So thinking about, you know, also looking at like telehealth and other options that will allow for us to be able to provide care for the communities that are being served.
Sunita.
We're sitting here, and how many of you feel like you've had this conversation before? A lot of us, right? So I'm struck by a couple of things, and I'll add a few things from Health Force Center. I think the conversation so far has laid out what you already know about the shortages, the burnout, issues around coordination, complexity, plus the transformations that are happening in our delivery systems, which stretch the workforce even thinner. And when we say workforce, we mean everybody. There isn't a workforce. It's particularly profound, I think, for behavioral health, but primary care. And you can go down the list and we can all give great examples. And probably, sadly, what most of us can speak to personally is whether or not you yourself or a family member has had challenge accessing care. And I think that brings home just how significant the issues are. They are not theoretical. And at Health Force Center, and I see my colleagues in the back table there, I think part of what we have done for a long time is to try to enumerate, and we're thrilled that HCI is doing this work on a statewide level, because that is the work that many have funded and supported, and it's terrific to see that, because I think getting data, being able to really see your own data, and to be able to make the regional and geographic decisions that people need to do workforce investments. What I'll focus on maybe is we have funding currently from the California Endowment to really develop a workforce policy center. And we see our charge as a couple of things, and if you go to the Health Force website, which is healthforce.ucsf.edu, you'll learn much more about us. But for more than 30 years, we have really been about the people in healthcare. And in particular, this effort is designed to really do a couple of things and to do it differently than we have done before. So we sit in an academic home. The advantage is that we want to think about our issues in a rigorous way, bring really important tools and deep, thoughtful process to it. And we need to be pragmatic, because the need is now, not 5 years from now, because that ship sailed a long time ago. So our work in this policy center is to do a couple of things. And I wish I could say we have made faster progress, but it is taking time to do for many of the reasons that you can understand in your organizations. But our goal is to do the work differently. So what does that mean? It means it's much more community-driven, not what we believe is important, not what the literature says is important, but it's driven much more by understanding from people. If you need information and evidence to take action, to drive policy, whether it's organizational policy, not just legislative policy, what do you need? What do you most wish existed? So that's partly that, and we've done that with listening sessions, sort of, I think, leveraging off of many of the things that ITUP has done, HCI, and many of you have done, is to really listen to people and ask them to help you understand what the needs are, not just assume that we understand all of the information. And the second is to take that information, take those needs that are expressed, and to turn that into actionable information that people can use to do advocacy and to do policy making. Because we are not in the position of being advocates, nor should we be, but we certainly partner, and that is, I think, a really important role that we see for ourselves, is partnering, whether it's with state agency or other organizations here and in the audience. So we have started our work. There's a couple things that you will see that are maybe familiar. They are briefs on if you want to understand what the evidence already is about many of the issues we've touched on, about problems with adequacy of faculty and training sites, and we haven't talked about educational debt, all of those things. It's Can we generate that information for you? It already exists, but how do we synthesize it in a way that's actionable and usable by you? That's one of our goals. The other is to talk about issues that are really changing. We haven't yet, and I know somebody else will bring it up, but artificial intelligence, right? It holds, we hope, a promise and some real concerns about, it isn't just about, we've learned from electronic health records that it's not about putting technology in place, it's about helping the workforce understand how to use that technology, ideally designing the technology in a way that it's useful and really is improving care, not just adding to systems. And so, and I can't help but, I do primary care, and I think that those realities, and I had a conversation last week where someone said, I'm really tired of hearing about burnout. Why is it still an issue? I'm like, because our systems haven't been fixed. It's an issue because people, and you said this, Alexis, people are working in those systems where the challenges are still the same thing. It's specialty shortages, it's administrative issues, but I think some promise in this new work, and so our role at Health Force Center will be to look at issues like artificial intelligence and workforce and say, not what is the technology, but what is the impact and the opportunity for the workforce. So I give you that as a little bit of a promise and maybe a tease, and really invite those of you that want to engage more and feel like, well, where is the evidence or information about this, that, or the other group of health workers, because there's so many, to connect with us and to guide us to really say, are you looking at this issue? And the last thing I'll end with, Crispine, is I think that there's the large elephant in the room. And that is, when we started this work a couple of years ago, it was really about the diversity of the workforce to mirror the needs of the population served, because it's better care. And we now live in a time, in the last few weeks, where people are feeling really challenged to be able to say those words, to talk about those issues. All of us, I think, to figure out, well, what is it that allows us to stay true to our values, to advance the work that we know needs to advance, but do it in a way that allows us to have some forward progress. I certainly don't claim to have the answers, but I just want to acknowledge that all of our conversation now really is shifted a little bit to make sense of that reality and to figure out how to keep having progress in that. And I'm an optimist. And so I hope for a couple things. There's incredible progress, and certainly with HCI and the immense amount of funding that the state has put into workforce in the last few years. And perhaps in this, and with really talented, thoughtful people working on the ground, I think really thinking about, well, where are the opportunities in the midst of chaos to really do things differently, to shake up sort of like the shoulds and woulds and musts, and think about solutions that really meet needs, but perhaps don't constrain us in the traditional ways that we have been constrained about payment and systems.
Great, thank you all. I think that there were definitely some points that resonated with the audience as well as myself. Especially, at the end of the day, we need the workforce to improve the patient experience as well, right? We ideally want people to come in through primary care, access that care, and then if more serious care is needed or specialty care, there is a transition. Like my sister Alexis over there, I am also a cancer survivor, and I understand what it means to have to carry your own data on a USB stick in your pocket and have to fill out forms each and every office you go to. And not to mention just managing all the different demands that come with taking 15 medications at one time. So you have to become a pharmacist, a nurse, pretty much everything. And so, I just want to remind us and ground us in, we want to do this work because at the end of the day, it is life and death for patients that are accessing the care. Libby, this next question is for you. What resources does the state have to better understand the distribution of healthcare workforce shortages, and what resources does the state have in place to support rural areas. I know you started to mention it, but I don't know if you want to give anything more details. And also, are workforce initiatives targeted for specific areas or professions?
Great question, thank you, and also great discussion. I wish we could respond to everything everyone has said. So I did talk a little bit already about our supply and demand modeling, which is new to us as a function in the state. It's new in terms of level of granularity and scope, and we've done it for behavioral health and nursing, are hoping to do it again, like I said, for midwifery workforce, primary care workforce, and oral health workforce, so that we have these really powerful tools to adjust and target our resources. So I'll describe a little bit about how we do that with just a couple of examples. So I talked earlier about infrastructure, training infrastructure, and training capacity as being a major barrier to health workforce scale and accessibility, particularly in underserved regions. We at HCI do have a suite of training capacity support and expansion programs. For example, some of you might be familiar with our Song Brown program, which we've been implementing for over 50 years at this point. The Song Brown program funds existing, expanding, and new primary care residency programs, as well as training programs for nurses, family nurse practitioners, and physician's assistants. And I'm really proud to share that we most recently added a Song Brown program for midwifery. So for the first time, we're able to use limited funds to try to award existing or incentivize the expansion of certified nurse midwifery programs, and we're hoping to be able to award a new licensed midwifery program. California has a birth equity issue, and we have 2 certified nurse midwifery programs and 0 licensed midwifery programs in the state. So really excited about kind of that tool, that programmatic tool, but just sort of how do we marry the two and use those programs to address areas of shortage or severe inequity. We do have a lot of interest in these programs. We always have typically more demand than we have resources. And so part of how we score our applicants and make difficult decisions is by preferencing programs that train their students in underserved areas, because we know if you train in an underserved area, you're more likely to practice in one. We preference and award points to programs that have strategies in place to attract and support a diverse student body for all the reasons we've already discussed. We know that's important for the experience of care. And going forward, we're going to integrate our supply and demand findings into award making to make sure that we're targeting the resources we have, again, to the areas with the greatest shortages and the greatest infrastructure needs. We also use, as another example, loan repayment programs as a mechanism to attract and retain providers in rural and underserved settings. We offer loan repayment to a wide range of health professionals and health worker types. And then in exchange, folks who get those awards agree to provide service in an underserved setting for a period of time. And our goal here is to address what somebody else already raised, which is the issue of sort of whether it's financially attractive or financially feasible for people to work in underserved settings. Sometimes it's easier to go work in the setting where there might not be as much demand. And so we're trying to sort of level that playing field a little bit. As a preview, I'm excited to share that under BH Connect, the workforce initiative, so many of you are familiar, BH Connect is a federal waiver that DHCS has pursued, and it includes a pretty significant workforce initiative up to $1.9 billion for 5 years to try to develop and expand the behavioral health workforce that serves Medi-Cal members and uninsured individuals. We're going to be able to, under this program, we'll have a specific program that provides recruitment bonuses, retention bonuses, supervision funding, and stipends for students to be able to do their funded clinical hours in FQHCs, rural health centers, hospitals that meet a specific Medi-Cal patient threshold, and county settings, which we know are hurting to attract and retain staff. So really excited about that as sort of another tool that's coming online. And I could share so much more, but again, I'm going to leave room for others.
Do any of the other speakers want to address any tools or resources that you have for people in the community that they could understand sort of where the shortages are or how to address them? I know UCSF has a lot of background research, which I have found, and I've heard from stakeholders of ours that look at our publications. Sometimes it's that information that helps them secure grants, that helps them really make the case for why more funding is necessary. But does anyone else want to add to that before I move on to the next question? Yeah.
I'll highlight one quick thing that the Policy Center that we're doing. We're doing this in partnership with Health Career Connections, who is really funded by the California Endowment to do real regional work. That's where the work needs to happen around thinking about workforce strategy and development. And one of the pieces that I'll highlight is really focused on creating a toolkit. This is what people have been asking for a long time, which is, it's great if I can access the data that HCI has and it's relevant to me. What happens when I don't have that data? Or what happens when I have different data? How do I do sense making? So part of the work that our team has been really leading is working with Health Career Connection and saying, let's create the toolkit, and then we'll need to do the next step of it, which is really ensuring that people know how to use it and have the technical assistance support. But that's a great example of the kind of product, if you will, that's trying to come out of this, is actionable, informational, locally relevant work.
Great. Anyone? Okay, so this next question is for Alexis. How does Transform Health approach workforce transformation, and how do you engage staff in this process? And secondly, do you have any efforts aimed at connecting the allied workforce, health workforce, to primary care teams?
Yeah, I really want to follow up on one of the comments that was made earlier. There is no way to exemplify how critical stakeholder engagement is. It is critical. For example, we are one of the designated facilitators for Los Angeles, one of the largest counties in the nation, where everyone has very specific needs. And we are working to align efforts. It has felt so fragmented. Going back to I really appreciated the feedback earlier, or the reflection earlier. We've heard a lot of this before. So how do we take what we know, leverage information, and align shared goals? So because of that, we have been reaching out to existing collaboratives, existing networks, convening and aligning our efforts so that way we can co-design solutions that are grassroots led. It cannot come from the top down. And resultant from that, we have been able to design priorities that are very specific to the workforce and led by the workforce. And it's also thinking about this from two perspectives, once again, going back to this matrix approach. What can we do in the long run that is really going to be policy oriented and is going to take a litany of conversations, work groups, so on and so forth to bring something to fruition? But what can we do right now? What is within our control? I know I provided the example earlier of aligning efforts and receiving feedback that the administrative burden was an acute issue that providers and managed care plans alike were feeling now. So that was something that the state, within a rapid period of time, I believe less than about a year, was able to deploy a policy improvement for. But we also received feedback, once again, by aligning efforts, that eligibility criteria was another hindrance to being able to access care. So that is another area where we're able to work with the providers themselves and hear that they're not able to serve as many folks as needed because their staff don't even have a clear understanding of the eligibility criteria. Transitioning this to the allied workforce, we recently, well, we're currently over the past few months been working with a National Physician Association, really trying to understand how primary care providers can better coordinate with, for example, CHWs. It was not shocking, but still really heart-wrenching that these folks, because of the fact that they are already at capacity, don't even have the ability to reach out to lead care managers on the ECM side or build relationships with CHW organizations, meaning that there's this entire component of the health force that's not being integrated or leveraged. So thinking about solutions, we're in conversations now to determine How can we intentionally coordinate that care? And when speaking with the IPAs, it was very simple. They let us know it's not going to happen by accident. There has to be a dedicated space, literally connecting the IPAs, the PPGs, with the CHWs, with various community-based organizations, so that way we can start to build those workflows to coordinate care. So once again, I'm a mom, I like to recap everything. Stakeholder engagement across collaboratives, across networks, and across sectors, hospitals, FQs, community-based organizations, the state, aligning those shared goals, figuring out what we can do right now, i.e. streamlining administrative processes, and then also what connections need to be facilitated, CHWs, IPAs, PPGs, and what do we need to do in the future, so that way folks can start to feel the immediate impacts of that low-hanging fruit.
That's great. Cindy, I have a question for you. What specific workforce challenges are you experiencing at the regional level, particularly in the Inland Empire, and how are you addressing workforce challenges at that regional level? And also, what resources or strategies are there in place, or collaboratives do you have in place to understand and tackle the workforce shortage?
Sure. So, as I mentioned, our workforce shortages and challenges are predominantly, looking at the pathway programs. We know that it takes a long time for someone to go through the program. We know that there's already a huge need that we'll see in the upcoming years with, individuals retiring and whatnot. So looking at that, it's a huge challenge because you have, your workforce is, retiring. We don't have a lot of individuals going through the pathway programs, and geographic challenges that I've already mentioned, and so on and so forth. And I feel like I'm preaching to the choir, so I will move on to some of the solutions or the little grain of salt that we're trying to do in our region to be able to kind of move these things forward. So, like you said, it's huge when we work with others because we want to make sure that we start tackling a lot of these things now. Otherwise, it's going to take us 10, 15 years to be able to see the results. So what we've done at the Community Health Associations, we partnered with El Sol, which is a community-based organization in the region. We've partnered with Reach Out. Both of those organizations have community health worker programs. And we've been able to get funding from different sources, including Kaiser, to be able to put some of our community members through the CHW programs. On one of the programs, what we did is took community members. We asked for community members who were interested in going through the programs to go through those programs. And then on the other side, there is a high school in the region that has students who are interested in the healthcare field, and when they graduate, they are MAs. So then we've put them through the CHW program so that we're able to kind of streamline them and help them there. And then from there, they go through the course, right, CHWs, but we know that it's so strained to be able to get them their hours that they need to be able to finish the program. So we've been able to connect them to community health centers so that they can finish their hours there. The challenge is, right now, there's 15 individuals going through the programs, and I'm like, we have about 100 and something clinics throughout the region, 114 actually, throughout the region that we can possibly place individuals at, and there's just like not that capacity to be able to do that. But 15 is a start. So I think that's a great start for those individuals that are going through the programs and being able to do that. And then also taking individuals who are already at our community health centers and are needing a little bit more guidance or maybe have that little push that they need. So we were able to do a program twice already. We've been able to replicate it where we've taken MAs who are not fully state licensed, and we've been able to bring them in. They already work at community health centers, so we've been able to upscale them and have them, do a 6-month, I think it was a 6-month course to be able to kind of rehash a lot of the things that they were doing and be able to prepare them to take the certification and guide them, literally handhold them through the whole process so that they finish this. whole program, and it's all for free. We want to make sure that we don't continue to add to any educational debt that they currently have. We know there was actually an article that came out last week on Health Affairs that talks about workforce challenges, and part of it said that, you know, a lot of the communities that are, you know, underserved and the workforce that kind of reflects that come from that community usually end up being individuals who are also low income and whatnot, and we want to make sure that we don't continue to add to their educational debt if there's any. So all of that, you know, is fully paid for them, and the past 2 programs that we've done, we've had about 40 individuals go through it. 20 something of them, 23 actually, have already finished and fully certified, and then our hopeful next step is to be able to move them on to something else and have them teach those under them to go through these programs, and hopefully any other things that they need to do to be able to kind of move up from there. And then also taking into consideration, in the Inland Empire, actually, the Community Health Association is also the Area Health Education Center, and so we're partnering with 9 universities in the region. We do have, I'm not entirely sure about the whole state, but we have a large concentration of medical schools with Loma Linda, with UCR, and whatnot. The Western University, we have a lot of universities there that are kind of churning out all these individuals and working with those universities to make sure that we do a program in community health, because I think it's really important for them to understand community health for students who are graduating. So we've been able to partner with some of these schools. 2 of them have fully implemented the community health certificate program and have been able to incorporate it into their curriculum. So now students can actually take that as an elective as they're going through medical school, rather than just doing it on their own. And it's important for them to really understand kind of those communities and be able to do that in that region. So those are, some of the ways that we're trying to address some of these challenges, but yeah. And then also walking the walk, at the Community Health Association, we had about 20 to 23 interns, and we've hired 13 of them already. So making sure that we're also growing the public health field so that we can work on all of that, a lot of those pieces.
Yeah, go ahead.
I just wanted to add on to that briefly. Number one, this is amazing. For everyone that's present, we did not talk about every single component of today's conversation. This is amazing. And the last comment that you stated about the interns themselves now having positions within the organization also reminds me of some of those best practices that we see coming out of the collaboratives that we're facilitating. Those organizations that are graduating, individuals that were navigating this complex care health system themselves going on to work at those organizations. That is where you see the most retention, is where they have been able to navigate that process themselves and see the benefits because they have lived it for themselves. And it's the acknowledgement for the employers, the organizations themselves, to see the value in being able to see these individuals as a commodity, like a really valuable piece of this problem that we're trying to solve.
No, absolutely. And I think it's not just about getting people into pipelines, but there's also a mentorship component that we haven't talked about. In addition to also stipends. I mean, people that are coming in, especially people with lived experience, have been incarcerated, have had, a hard time finding any employment. They need childcare. They help their families. And so all of those things factor in as they're deciding, do I want to go back to school? Can I afford to go back to school? And I was just on a panel last week for Health Career Connections, and just reminding people there is this is especially resonates with first-gen people going through the education system, that there are more jobs than just being a doctor or a nurse, and that we're all necessary to build out that ecosystem to be able to have conversations like this. So we have time for 2 quick questions. So if there's anyone brave in the audience that would like to ask a question, here we go. Question 1.
Hi, David Panish, California Health Policy Strategies. I'm curious how we're coordinating with, here's Herb Schultz. I have a question on how we're coordinating with Medi-Cal managed care plans that have made a lot of strategic investments on workforce, and just sort of curious how that money is being integrated, whether that's effective. Is that a good model? Is that something that we should be exploring further?
Yes.
Hi, David. I have a yes and response. So 2 perspectives that I can offer from our work with the collaboratives. Number 1, we are supporting the administration of the incentive payment programs. And so because of that, the managed care plans want to know what was the return on these investments in being able to build up CBO capacity to integrate into the healthcare landscape? So it's a question that our managed care partners are actively asking. What are the evaluation questions that would demonstrate success and therefore trickle back up to the CalAIM evaluation plan? How has expanding workforce within the context of ECM and CES helped DHCS meet its evaluation needs? So that's an active question that's occurring. On the other side of it, managed care plans or partners have also reached out to say, and I think it requires a tremendous amount of vulnerability and courage to be able to say, hey, we have never deployed a health equity initiative of this size and scale before. We want to completely reorganize and restructure internally to figure out how to build processes that work for varying levels of expertise, education, experiences, so on and so forth. And so I think that's a very important investment that the managed care plans are making by saying, hey, we want to restructure internally to align our processes with those that will make implementation easier for community-based organizations, not just FQs and hospitals. So it's a yes and from my perspective and experiences. The partners trying to figure out what success looks like, how can they gauge a return, and part 2, realizing that internal investments have to be made to completely restructure and reshift how they operate, which really is demonstrative of a shift to value-based care, because they are thinking about the needs gaps, the gap filling plans that they want to demonstrate with DHCS, and really building a robust network that is going to help them meet those gaps. So not just thinking about the financial components, but really the value add that this network is going to establish. So sorry, it's a yes and from my perspective, and welcoming other responses as well.
Yeah, if not, we'll take the second question. I saw a hand over here somewhere. No? Did we shy? Are we shy? No? Yes, up here. There's one.
First of all, thanks for all the things that you've shared. It's encouraging to hear that this work is being done in other sectors. I work for one of the managed care plans, and in hearing so much about cross-sector approaches, I'm still finding that oftentimes at the managed care plan, we're handed policies that have been discussed by a number of different people and said, this is the rules now, and we didn't get a chance to sit at the table and help where it would have been very valuable. Managed care is in place to improve efficiency of the delivery of Medicaid, yet we weren't there to do that. So is there any, and I hear some of you saying that managed care has been at the table, is that only happening with certain plans in certain regions, and is there a way that we could organize through CAPS or other organizations out there to really get a unified voice for managed care in these initiatives?
Does anyone?
Can I answer this one? So I'm going to put my health policy hat on, and I think it just really depends. So I'll tell you kind of where we're at right now, and I think you bring up a really good point. For example, so in the Inland Empire, we work with IHP and Molina. So with IHP, I'm connected with their government affairs person, and then what we do is actually we kind of have coffee every quarter or whatnot. We've turned that into every other week having a call, because there's just so much going on that things change. I mean, I'm literally afraid to take off my phone off airplane mode right now when I get back down there, because this morning things were just changing so much. So, so what we've done is kind of created this check-in with each other every other week to just talk about different things that we're both doing in our work in terms of policy at regional levels, but then also at the state level. It's my understanding that they also work with their local health plans, I believe, in Sacramento. So then those individuals are also touching base. But I think it's really important for us to kind of build that, because it was just by chance that we were like, hey, we should just really sit with each other and talk about all of these things. So it's not something that's been established, and I don't know. I'm pretty sure something similar has to be going on, throughout the state. But I think it's something that it takes, for individuals to kind of start piecing the points. So then now you have the clinics and the plans, and then who else do we need to include in our, biweekly check-ins, so that we're having a comprehensive way of answering to all of these and ensuring that we're including your feedback as well.
And I will just say that at ITUP, we tried to be the big tent, right, where everyone can come, everyone can contribute, and that those contributions are valued. And we try to uplift them when we do engage state policymakers. But you play a critical role, right, in addressing some of these issues and providing the incentives. And so, we would welcome any health plan to work with us as we establish what are our priorities and how do we get there. Because I think we all have a stake in that. So before we wrap up, I know that we're right before a break for coffee and everything else that people need. What is one optimistic takeaway that you can share with the audience? I know that's tough, but I think in this time that we're in, right, with the elimination of DEI and attacking the immigrant communities and rolling back coverage, I think that we can't lose our spirit, right? And that we have to be strong as a community to be able to tackle those challenges. So, yeah, what is helping you individually navigate this?
I can chime in. I don't know if folks can tell, but it's hard for me to shut up sometimes. I have been thinking about this a lot recently, especially as the mother of Black children, like I stated earlier, a complex care patient myself. I have been working with hundreds of providers across the state, specifically in Los Angeles, and what I am encouraging folks to do is focus on what's actually within our control. And so I really see so much hope and so much optimism in being able to say, although there are certain policies that we are working on that are going to take time to effectuate, what can we concurrently do right now? It's tackling both of those at the same time. And when you are able to experience the benefits of that, once again, that low-hanging fruit, and see, wow, we were able to increase how many members we were able to serve this month because this process was streamlined, because this burden was removed, because we built a new referral pipeline with this FQ. That is hopeful, it's encouraging, it's inspiring, and so it's focusing on the long run while still being able to manage something that is more tangible and immediate and concrete. So focusing on what's within our control.
Thank you.
Yeah. I'll just piggyback on that a bit. I think particularly on the question of sort of in the current climate, how do we continue to support diversifying the workforce? How do we promote DEI in the workforce? Just to echo the sentiment shared earlier, we definitely at HCI think about workforce development as kind of like a double bottom line. We're both improving population level health outcomes, and we're creating economic opportunity for people who have not traditionally had access to careers in health professions. And I will say we've been doing that under the constraints of Prop 209 for years. So yes, we're in a new federal environment, but we've been kind of working around some of those constraints for a long time. And I guess what keeps me optimistic is that constraints breeds creativity, and it's going to force all of us to think really hard about what we're trying to accomplish and what are the creative ways that we can get there. And echoing what you just shared, I say this to my team all the time. We were in a tough budget year last year. We're in a tough political climate this year, and we will still continue to do the best we can with what we have. And that's what keeps me optimistic.
ditto, but also what also gives me hope is, you know, just taking it in a broader like lens, is that I'm seeing a lot of youth really be empowered and wanting to learn about different fields and wanting to, you know, kind of, you know, sometimes I feel like it's like you're a doctor and then that's it in terms of healthcare, and I think I'm seeing that change or that shift be a lot more present now. So I think that gives me hope on top of all of this stuff. And then the other thing is, you know, just our communities, being able to help individuals in their language or whatnot. I think sometimes I do get bogged down because, you know, you're maybe not working with the community, but every so often I do get to go out to communities and whatnot, and I see my parents, you know, whenever I go to these communities, I see their faces like in our community. So I think that gives me a lot of hope to continue to do the work that we do, and hopefully we can continue to expand on a lot of these projects that we're doing so that we can make a bigger dent in the community.
I'll add two things to what keeps me hopeful. One of them, we know a lot of what works. So it's not like we're in search of solutions. We're searching of how to implement solutions, which I think is different and needs to be tailored to the settings that we're in. But the issues are really well defined, as we described again today. So it's really thinking about in the environment what's possible to do and how to solve the issues. I would say probably the biggest hope is the theme that has come up here. It's about partnerships. You cannot do it in a sector. Otherwise, we're just poaching from each other. You have to do it so it's not regionally bound or city bound or county bound. And so I think the exciting thing is what's happening both at the state level, but these examples of people finding partners, spending time building trust so that you can actually try and test and do new things. That actually makes me very excited, because I think that's where the potential is solving those real, very real problems and needs.
Can I add one really quickly?
Sure, quickly.
Very quickly, I'll just say that community health workers also give me hope. They're people who've been doing really hard work in communities for a long time, and I think about all the people who are doing great work right now to promote health and legal security, in immigrant communities, and I look at that and I'm like, we're gonna get it done. We're gonna get around it. So.
Well, thank you to our panel. Thank you. We now have a networking break. We do ask to return back to this room by 2:45, but once again, help me thank our panel today. Thank you.
All right, let's get started. Good afternoon, everyone, and welcome to today's workshop, Mobilizing to Shape Future Policy Opportunities. Before we get started with today's workshop, though, let me introduce myself. My name is Jana Wright. I am the Director of Policy here at ITUP. Really pleased to see a lot of you, a lot of familiar faces and some new ones. So if we haven't met, please be sure to grab me tonight at our dinner. I would love to spend some time talking to you. Before we dig into our policy workshop, though, I'm going to invite Elisa Coe from HealthNet to share more about what HealthNet is doing to strengthen the workforce opportunities in the state of California. Elisa, take it away.
Thanks, Jana, and want to thank the ITUP staff, Shirley, Crispin, and others. Always an event I enjoy attending every year. Once again, Elisa Coe, I'm the Senior Director of Public Affairs at HealthNet, and as many of you know, we represent almost 3 million members across the state. 85% of our members are government-sponsored healthcare, and we are in 14 Medi-Cal counties that represent the rural, the urban counties in California. So Jenna invited me to speak to just talk about the bridge between workforce and policy. I'm going to start with a few facts. Right, by 2030, there's going to be an 8,800 shortfall for primary care doctors in California. We know that Black maternal deaths are 3 times more likely. Transgender are 3 to 4 times more likely to experience trauma compared to the cisgender, and then there's ands and ands with other different populations, right? We know that culturally congruent care produces better health outcomes. So as we strive to think about our workforce and how we are expanding our workforce and being intentional how we do it, right? How do they represent our population? How are we making sure that community feedback is helping us as we're striving to make it more representative of our population here in California? How are we training our current workforce, right, to make sure they're providing the care to the populations they serve? At HealthNet, we really think about these three different aspects as we are investing. I remember somebody talking about how health plans work with others, right? At HealthNet, we really think of those three things. And so we've done grants like investing in doulas before it became a benefit for Medi-Cal. I see Catherine over there, my partner in a Latino workforce physician space, right? How we got together 40 experts together to really think about and be intentional about creating a roadmap to increase Latino physicians. What are we doing in the community health workspace, right? And working, HealthNet has worked with community colleges and creating a certificate program, training program so that they understand health insurance, they understand different things. So really excited about the next session and all of the workshops that Jan is going to do with you all, and hopefully we come up with some great ideas together. Thank you.
Thank you, Elisa. I really appreciate you sharing some work that HealthNet's doing. Thank you so much. So as we're gathering here today, a lot has happened in the last 3 weeks. I have a script here, and I probably am just going to end up going off script because it has been a difficult time for many of us. I live in Los Angeles. I have seen ice most days of the week in my community of Echo Park. We are dealing with LA wildfires. We are dealing with unprecedented cuts at the federal level, and it is no small thing that you are here. You are here at a conference which equity is in the title, so I thank you for being here. It's important that you're here. Thank you for your dedication. So like I said, we're facing some significant challenges today in terms of shaping the future of health policy. When I really talk to you more about Medicaid, though, this is going to be part of this workshop. And I'll say, prior to the election results in November, we really hadn't thought much about putting Medicaid on the agenda in terms of this policy workshop. We had a completely different plan. So we have had to change and adapt quickly to the times. But I want to talk to you a little bit about what is at stake. So 15 million Californians rely on Medicaid. That's 1 in 2 children. It's 1 in 4 individuals who are seniors and people with disabilities. It's 1 in 3 Californians. Additionally, 823,000 seniors and people with disabilities depend on Medi-Cal in-home services, in-home supportive services, IHSS. But let's take it down to a county level. What does that mean? 23% of Humboldt County residents depend on Medicaid. They could end up losing coverage under some of the things that are being proposed, like per capita caps, block grants, work requirements, changes to the FMAP, the federal assistance matching percentage, and rolling back Medicaid expansion. So for some more counties, though, 32.9% for Kern County, 40.3% for Los Angeles County, and 26.7% for Glenn County. And let's be clear that any cuts to Medicaid is not going to help our rural hospital closure crisis that we're currently facing in the state. Additionally, if Congress fails to act to stabilize state-based exchanges like Covered California, 1.4 million Californians could see their costs spike by $1,000 per year on average. But while we face these significant challenges, we also have additional opportunities to push forward solutions that improve access and, yes, equity. One promising area is the recent wave of newly introduced legislation by Health Chair Bonta aimed at addressing maternity care deserts. These bills are a direct response to California's ongoing maternal health crisis, and they represent a step forward towards closing those gaps in care and improving maternal and birth outcomes across the state. So as we look ahead, the question isn't just how do we defend Medicaid, it's how we strengthen it to meet today's challenges and tomorrow's needs. How do we ensure that any policy changes support a robust, diverse, and sustainable workforce? How do we advance health equity so that every Californian, regardless of income or geography, I'm from a rural area, so I'm going to say geography, has access to the care that they need? That's exactly what today's session is about through expert insights and interactive discussions. We're going to explore some tools, some strategies, and some advocacy approaches needed to shape policies that protect access to care and build a stronger, more resilient healthcare system. Again, I just want to thank you so much from the bottom of my heart for being here today. I really appreciate you joining us for this session, and I'm going to ask you now to turn to your table mates and say hello. And if you're at a table with one other person, you may want to think about joining another table. So say hello, get familiar. This would work really well with 4 to 5 people at your table. All right, did you get to know everybody? Yeah? Okay, great, because these are the people you're going to be working with this afternoon. Okay, so we're going to take questions one by one. I'm going to get off the stage and walk around with the clicker so we can be in community together. But some instructions before we get started. So you're going to work together at your table, but you're all best friends already, so this is great. Step 1, already done. Please use the paper and markers. You all have paper and markers? Yes, okay. Use the paper and markers provided to answer the following discussion questions, and please go ahead and identify a note taker and a report out. So this is how we're going to do this. We have questions on the slides. We're going to go one by one for each question. We're going to give like 10 to 11 minutes per question. When the time is up, I'll move on to the next question, and then at the end, we're going to have a report out. Okay, sound good? Any questions? Can you tell I'm a mom? Okay, great. Let's go. Not surprisingly, the first question is about Medicaid. What are the most critical challenges facing Medicaid, and what key messages can effectively counter the cuts? 10 to 11 minutes. Go ahead. We can give you more paper if you need it. Oh, just kidding. That's all we have. So do like one question per page. Good? One question per page.
All right, everyone. Time is up. So, Jana, shall we get started on reporting out?
Yeah, who wants to be the lucky first 2 tables to go? So we're going to do 2 tables per question for report out. So oh, look. I love a volunteer. Thank you. I actually volunteered her. Perfect. A voluntold. Absolutely great.
That
Let's
made it
go.
really easy to volunteer. So at our table, we talked about lots of critical challenges facing Medicaid, but wanting to highlight the rampant misinformation that's being put out at both the local, state, and federal levels. It depends on who you're talking to. Members may not be getting the correct information, and that causes a lot of anxiety. And then for the key messages to effectively counter cuts, one of the things that we talked about at our table was really putting a face to each of the numbers and statistics. When we talk about 15 million Medi-Cal members, each of those members are a person. And so if we can share the stories of those members and really get across to our legislators that these are people whose lives are being impacted by the policies that are being made at the federal and state levels, that would be really effective in countering some of these cuts.
Thank you so much. Wonderful. All right, one more table. Here we go. Thank you. Tim Sharp's table.
Oh, the microphone, thanks. So, we have a whole long list of critical challenges. A lot of them were listed: access to care, workforce development, housing resources that are named in policy, but there aren't actual any real houses you can go touch. Reimbursement rates, provider groups not wanting to serve Medi-Cal because of reimbursement rates and fear of change around that. Wage increases, could minimum wage things be applied in healthcare settings and home health settings, et cetera, et cetera. With our key messaging, we tried to keep in mind sort of the culture of the current administration and what might speak to them. And, you know, in my mind, that comes down to how do we look, right? How do we appear? And so pointing out 1 out of 2 children being covered by these services in Humboldt County. Are you going to get at the podium and say, yeah, we're going to say half of the children shouldn't survive, right? Talk about pre-ACA and pre-pandemic situation. What was it like then? How did we get to preventative care and access to primary care? The prevention of upstream care and preventative care is likely to increase burden on emergency services, which brings us to that final thing. Again, there are people in the administration and around the country who may not want to hear about those people and other people, right? Well, what about your people when the ER is full? Think about during the pandemic, the people in this country got to experience for the first time being turned away at the hospital. That's a new thing, and that is a potential result of eliminating these upstream services and forcing everybody into emergency care, which there isn't an option for the federal spending to stop paying for. So,
Ooh, 2 volunteers from the same table.
I just came back late, that's why. I'm sorry. I just want to add the component of the culture and linguistic stigma. You know, there's no one size that fits all. So my point that being in a community clinic, we are constrained to who we can see and what we can receive. And when you do not have your first language being English, like myself, you don't really get all the privileges, like to be able to know, oh, I need to see a specialty care or something that would help me. I mean, I remember distinctly I'm from Marin County, going down to San Rafael Clinic, just FYI. I was sitting waiting for my turn, and I saw this man came in. He was just sitting down there. He's an Asian person, and I guess the daughter just dropped him there. And the person came, she put the copy of document right to the front desk, and she left. And he was supposed to wait for his turn. Twice the person come out, and I was like, nobody, and I just thought maybe it's someone else, and I realized maybe it could be him. So realizing he's Asian, I tried to connect with him. He's Vietnamese, I'm not, but somehow some Vietnamese I know they speak Cantonese, which I do. So I asked, excuse me, what are you doing here? He said, I'm waiting to be seen. I said, are you here for blood work? And he said, yeah. And I said, what's your name? And he said, I can't, just show me the name. And I was like, are you calling for this person? He said, yeah, we've been calling him twice. Nobody came out. We thought he's not here. There is this poor person sitting here. Just because of the language component, he wasn't seen. So this is something I want to say, a snapshot of a community clinic. And second thing I want to bring to attention is that when a specialty care person leaves from the clinic who, because it's a community clinic, of course, you're not paid too well, but there are people who actually have the passion to help. And when money comes a problem, they want to move on. Just like now, our acupuncturist left, and I have to go to another county to be seen because I have chronic ailments and stuff like that. But my point to you is that there are a lot of challenges, one top another, when the first language is not English. Second, when you actually do not have the culture, the norms that you do, certain cultures has a certain norm they do not raise and talk to you, but that doesn't mean the issue doesn't exist. So these are 2 points I'd like to bring to you. Thank you.
Thank you so much. Really appreciate those key messages and you sharing just a snapshot of what's happening in community clinics across the state. All right, let's move on to our second question. The next few questions are me focused on the healthcare workforce, kind of the theme of today, if you haven't recognized that yet thus far, but still wanted to get in a question about Medicaid. So the next question is, what are the most significant workforce-related challenges California faces in maintaining and expanding healthcare access, particularly in underserved communities? So same process, we'll give you about 10, 11 minutes, and we'll do another report out. All right, I think we've got time for 3 tables to go. So preferably not the tables who have already gone.
Coming.
So who wants to go first? Look, we have a volunteer. I love that y'all are volunteering and you're meeting the moment and I don't have to call on anybody. This is great. Thank you.
Thank you. Okay, so our conversation about workforce-related challenges was really varied, and that's because in California the challenges vary and they're very specific to location. But we zeroed in a lot talking about the cost of housing. That's pretty much universally an issue. And then encouraging people to relocate, especially when you get into like physician and NP and positions that you have people relocate for. It's hard to convince your family to move or convince your spouse to move, especially if it's a rural area. And so some of the ways to maintain and expand healthcare access, we had a lot of discussion on that. We did zero in on rural counties, and we talked about a grant program that we're releasing this week at my work called Building the Healthcare Workforce Grant. And it's actually fairly open-ended, and it's going to be aimed at helping counties expand their healthcare workforces through creating educational pathways or stipend programs. And one of the biggest things we talked about, and one of the goals of my work, County Medical Services Program, and releasing this, is being agile and allowing individual counties and individual locales determine their needs and then create a project in relation to that. So I think the biggest takeaway for us is the needs vary, and so the solutions need to vary.
Great. Name and organization in case people want to connect with you later.
Oh, Laura Moyer, Grants Administrator, County Medical Services Program.
Thank you. All right, another table. Now I saw your notes, so I know that you took good notes. So you've got plenty to say, so don't be shy. Can't see you through this orchid. Here you go. To my left.
Okay, so I have, on behalf of our group, we came up with geographic distribution, workforce, and education and training, insufficient provider workforce, behavioral health, primary and specialty care, insufficient wages and jobs for spouses and partners, retirement, providers don't represent the population, long, arduous pipeline, especially to the physician, educational capacity, for the upcoming workers and doctors and so forth is insufficient. The behavioral health, stigma, burnout, and the pipeline compassion. Oh, no, I'm sorry, that's what pipeline. And then turnover, burnout, and compassion fatigue. Oh, wait, we have more. Okay. Administrative burden, underserved communities that might be less desirable in terms of community resources such as housing and schools.
Thank you. Name and organization, please.
Yes, my name is Susan O'Keefe. I'm with San Francisco Health Plan.
Thank you. All right, another table. Oh, look at these brave souls. Thank you. In the back.
We focused a lot on the pipeline, so a lot of things that we've already heard, but quite a bit on those barriers within the pipeline, whether it is the time and cost of training, both to the organization and also to the student, and concerns about whether federal loan forgiveness continues. An interesting discussion about how we support our workforce as we're focusing on creating a more diverse workforce with more lived experience, that we have to, in the workplace, support more diversity and support people better if we are valuing that lived experience. That just people are coming from different places and need more support in their workplace. Lots of barriers within the career ladder pipeline. The unpaid training and internships came up in a couple different spaces. and then the predatory loans and the cycle of debt that you can get into as a student. And then in terms of burnout, just the generational impact of COVID, whether it's hollowing out levels of our healthcare workforce that then don't move up the career ladder, or within the behavioral health space, that real move toward telehealth and how that will impact the ability for behavioral health workers to then be in the clinic setting as well as the telehealth.
Thank you. Can I add to your comments about telehealth and behavioral health? One thing we are learning over the summer with our regional equity collaboratives, at behavioral health, the exact thing you're talking about. So behavioral health specialists moved to telehealth during the pandemic, which was great because they're still able to see their clients. But this really impacted older adults. So I want to call that out. That's a lesson learned from the year from ITUP. And would you like to share your name and organization with us? Samara, thank you.
United Healthcare Workers.
Thank you. All right, ready to go to the next question? You all look so jazzed. Okay, I know, but you're going to be rewarded with cocktails and dinner tonight, so it's going to be great. You're going to have a great time. Okay, let's move on. Question 3. How can California's innovative healthcare models and resources be leveraged to address workforce shortages and enhance healthcare delivery? What are the untapped resources despite federal uncertainties? I'm going to add a little bit of commentary to this question. So we know that California is the best state in the union. Yes, we know that. Yes. However, there are other states that have ideas that may work for at least some of our geography. So feel free to uplift any of those in your conversation as well. All right, same format, 10 to 11 minutes, and then we'll do a report out. Okay, who is going to go first for report out? Look at this table in the back. So eager. Thank you.
Thank you. So I think we talked earlier, someone on the panel talked earlier about regional models, and we think that if we could have some way to kind of share all of the innovative regional models on workforce strategies, we'd all learn a lot. So something like a statewide show and tell. So maybe that's something ITUP could put together later. But it's like, come and share your innovative practice. I don't know, maybe there's money attached, maybe there's some incentive, but we know that it's out there and we want to learn about it. We also talked a lot about some of the various state resources that are maybe underutilized, like the public library system. We know that Covered California used it recently to kind of put out information about, the marketplace and applying for Medi-Cal and things like that. And then we talked a lot about just how can we focus on youth programs. So how can we educate individuals maybe at the high school level about some of the options that's available to them. I know there's a high school here in Sacramento where they have a CTE program that if you go through it, focused on the medical field, if you go through it, you graduate as a certified medical assistant. So you can work as a medical assistant while you're going to college and figure out, do I want to continue my career in healthcare? Do I want to just become am I okay, just working as a medical assistant? And then we think that there's a lot of opportunity for loan forgiveness. So for individuals who, maybe they grow up in an underserved community, they leave to go to medical school, if they come back and operate or work in the underserved community, then there's loan forgiveness options.
Thank you. And name and organization, please.
I'm Carly Holko. I'm with the California PACE Association.
Thank you. All right, I like your idea of regional workforce practice collaboratives. All right, who's next?
Hi, 3 really different ideas. We talked a little bit how ECM, I am from New York, but I live in Contra Costa County. I said talk and I saw the smiles. Yes, I saw all of you. I talk, I walk, I drink coffee, but I live in Richmond. We talked a lot about how there is a propagation in CMMI waivers of what we in California call enhanced care management. We're excited about that. What we're less excited about is when the waiver goes away, what happens to those people who are on case management, and as of Jan 1, they're still gonna need case management. One of the things that California has that's pretty innovative in comparison to other states where we are ahead is we have the CHW service benefit, don't we? And it's close enough to ECM that it is deemed a duplication of service. And so if we're gonna lean into the stuff that we've already created, thinking now about the intersections between ECM and CHW and really increasing utilization. Listen, I know the rates are bad. I've been in the streets, I've been a CHW, I know they're bad, but they exist, so let's start somewhere. Looking at those intersections, building those glide paths, and increasing utility of the CHW services benefit, I really do think would keep us at the front of the curve of the intersection of healthcare and social services, especially after the waiver ends. Take a hard right turn. We're going to talk about rural communities for a second. We're going to talk about telehealth. We're going to talk about broadband needs, capital I infrastructure needs, right? Like, I can't do a telehealth visit. You have to drive 4 hours for a specialty because literally the internet doesn't work here. Lo siento. Not good enough, right? In the state, I was gonna say country, WIPA, in the state of Silicon Valley, like, why can we not invest in our technical infrastructure to increase access to technology issues like telehealth for especially our rural communities? Take another hard right with me. We're going to talk about leveraging the data exchange framework, which is the rules and regulations to support those that have opted into and or have been voluntold to opt into, healthcare providers. Data exchange. We have a real opportunity to demonstrate the impact of work at the intersection of healthcare and social services if we actually use the data exchange framework. And if we are bold enough to invest our own resources and using that data to tell the story of what happens when I'm a CHW inside of a community clinic and I make a referral to a legal aid service, what happens on the value proposition on both sides of those service providers? Because there's value there, and we actually have access to that data. It's another tool in our toolbox I think is underutilized, but if we can like push things down the pipe and maybe fund some of that pushing, I think we can get somewhere.
Name and organization, please.
Sure. Lauren Panaccio, she, her, aya pronoun series. I'm with a consulting firm called Intrepid Ascent.
And that, dear audience, is the overview of our agenda for tomorrow. Thank you so much for your comments. All right, one more table. I'm going to call. Well, okay, yes, and then I have another table that I'm going to pick on. So,
hi.
Hi.
Also not originally from California, but do live and work here.
Woo, transplants.
Right? International transplants. So we had some really interesting conversations about, innovative responses. And one thing, my name's Heather Porter. I work for the Rao Family Foundation. We're based in Upland, California, and we focus entirely on the Inland Empire. We have dipped into Imperial County now as well. But we've recently funded a GME consortia amongst FQs in the Inland Empire surrounding the Salton Sea, and this consortia is essentially going to provide 5 or 6 new residency programs in the community. It's entirely focused on recruitment and retention within the community. We also support, when so many people talking about debt relief, debt reduction strategies, we support both full and partial scholarships on the front end, and then we're looking at loan forgiveness on the back end in support of, again, trying to recruit and retain in community. We also funded a program for telehealth with a school district. It was really interesting. We thought it was reasonably innovative, but essentially we helped to fund between a very large public pediatric hospital and a school district, which is the most underserved. And day one, within the first 5 minutes, we started getting phone calls for emergent medicine and for pediatric support for managing chronic illness. And again, just talking more about collaboration and support across the board. I'm trying to think, do you want to talk about your pre-health? She's like, no, I'm not doing it. The California Endowment, who I don't work for, has an amazing program called Pre-Health Dreamers. they fund a program called Pre-Health Dreamers, which supports undocumented, DACA, and no social security number students in being able to get through medical school. And a lot of people can get through medical school, but then they're actually prevented from doing their clinical hours based on various requirements from hospitals. But this program actually helps them to be able to achieve those clinical hours. It also includes an entrepreneurship program post-medical school. Thank you.
Thank you. All right, Cindy Sanchez, you haven't talked yet, and you have to talk, so here you go. I told you were going to have to do this. I don't know why you didn't just volunteer. You brought
being
this
up
on
there
yourself.
wasn't enough. Okay. So we were talking about short-term solutions and long-term solutions. So we actually talked about out-of-state providers for our short-term solutions, as well as out-of-country physicians. Like, there's two bills last year, AB 2860, in terms of being able to bring Mexican physicians to California to work in rural areas. And then also SB 233, which that one's out of state, and that one was particularly of interest for some of us because we have a clinic that's like in Needles, and the closest like clinic that individuals can go to is in the Arizona side, and it's like 20 miles from there. Yet there is not that like translation or that talk between both states to be able to have the patient go to that clinic for some specialty services and stuff like that. So. And then long-term solutions, I mean, we're talking about pathway programs, also tapping into having individuals that are in the country, that are from other countries that are fully trained, but just need that extra push or that assistance to be able to go through certifications that they might need to be able to practice what they studied in their home countries here. Sometimes they might find it difficult or might not have the financial means to do that.
Thank you, Cindy, and her table. All right, we're going to move on to the last question. Yay! I need more excitement. You're not giving me anything, and I'm up here one woman showing. Okay? You need some more excitement. Get jazzed. Ready? Okay. Yes! This is great! Yes. All right. Let's pretend the Rams made it to the Super Bowl. Yay! Okay. Question 4, or whatever your team is, 49ers, that's okay. Question 4 is, what advocacy strategies and policy actions can be used to influence policymakers in California to prioritize workforce development? Other than attending this session, we know that's one, but other things that we could do. All right, I'm going to give you a little bit shorter time for this one, maybe like 7 to 8 minutes, because I want to get you out of here on time, okay? Take it away. All right, wrap up those final comments. Wrap up the final comments. We're gonna do some more report outs. Okay, who hasn't gone yet? Oh, look over here. Okay, I'm coming. I'm only as fast as my shoes, which clearly is not that fast today. Here you go.
Hi everyone, I'm Rebecca Stark. I'm with Partnership Health Plan. So at our table, we were kind of talking about how a strategy we could use is, like I think someone mentioned this earlier, is to use storytelling to paint the picture in California, just of who the members really are and how this really is going to affect them if they lose their coverage. We also talked about using data-driven evidence to also, paint the picture as well, using data. We all love data. Some other ways that we discussed at our table is maybe some creative ways we could generate additional revenue. I know we all hate paying taxes, but maybe a little bit of money in some different areas we could actually use to put more towards healthcare. We also talked about building relationships with our legislation, lobbying, power in numbers, voting, also using some educational campaigns and using social media to inform everyone of the issues at hand, engaging stakeholders, and maybe something that's kind of old school, but doing letter writing campaigns.
Thank you. Name and organization.
Oh, I said it at the beginning. Rebecca Stark, Partnership Health Plan. Thank you.
Thank you. All right, who else wants to go? To my left. Ooh, look at this this little table back here has been working hard the whole time, so I'm so glad they volunteered. Go ahead.
Thank you so much. Good afternoon, everyone. My name is Lindsay Richard with the California Abundant Birth Project, a guaranteed income program. One of the main things our table really explored was the importance of, similar to what the other table had stated, but storytelling, the power of just voicing one's experience and their concerns. In addition to creating policy advocacy groups, bringing in community members, informing them on the importance of policy actions, what it means to empower them to get in front of these important folks and stake their case, even if it's uncomfortable. In addition to that, really leaning on community leaders, identifying who's in your community that is sort of known in these streets to really assist you, really leaning on who they know that can assist us to really promote the specific topic at hand. It's always a situation of sometimes not what you know, but who you know. In addition to that, one of the things that I love to do is holding folks accountable. Okay, you promised this, so from that point that you promised and you actually started your work to now, what has been done? Nothing. So let's actually showcase that, whether it be on social media, as we know that that's very powerful, in addition to other avenues to really showcase that, okay, they're saying this, but their words do not match their actions. And that's it for our table.
Thank you. Your comments about accountability got me thinking about continuous coverage for kids 0 to 5. So yes, holding people accountable for the investments they've previously committed to. All right, let's do one more table. Yes, over here in the kind of the middle to my right.
Hi there, my name is Bao Zhang with SenCal. In addition to what has already been mentioned by the other two tables, I'll just highlight one additional strategy, and that's really speaking to the economic impact of workforce development initiatives, recognizing that the investment that's being made into workforce, there's going to be an ROI. We are training individuals who are going to then become employed within the healthcare space, who are going to be tax paying, who are going to be contributing financially to the communities that they live and work in.
Thank you. All right, that's it for a report out for this question, but I want to ask you for any last burning comments you may have, anything that you didn't get to say today that's really important to you that you want to share with the group. Everyone's ready for a cocktail. Okay. Me too. But I want to uplift. I feel like there's some comments, maybe from this table. No? Yes? Yeah.
This might be rhetorical. I'm wondering if healthcare is top of fold to our policymakers within the state. Like, is that a 2025 priority within California? Anybody know? It used to be, but seems to have fallen off the radar. And not just healthcare, health and social services.
Can I provide an answer to your question? So we know the governor's priorities are two things. One, recovering from the wildfires in LA, and the second one is affordability. And I think as much as we can, to your point, connect healthcare to affordability, the better off we're going to be. Affordability is not just housing. It's not just utilities. It's not just the groceries you pick up at the store. It's also healthcare. Because if we lower egg prices, but all of a sudden you're paying $45 co-payments for a primary care visit, that would be an issue for most Californians. So just want to call that out as a question. I answered your question. Any other top line things you want to say? Burning comments. Ooh, back in the corner again.
One additional thing I didn't get to say, I think it was maybe the first or second question, is one thing we're doing in LA County, and I know throughout California, but one thing I really want to see us expand on is MDTs or multidisciplinary teams in addition to mobile vaccines for healthcare, meeting folks where they're at. A lot of our vulnerable populations, is so difficult to get to these FQHCs and just getting the very bare minimum and basic needs met. So seeing an increase in some way where we can bring these services to them to really help them with the various needs that they have.
Thank you. Any other last comments? Yes, my friend from New York.
Sorry, thank you. It's a bit less big word voice. Okay, yeah, sure. So the thing that I would offer is, as we increasingly look at growing the bench of who is and isn't a healthcare provider, the work that we need to do advocacy strategies to support us, not in 2025, this is longer term, is investing in monitoring and evaluation that looks at the impact at the intersection of healthcare and social services today to help answer the question in 2030, what did I get out of this social service investment as a part of healthcare? If we don't start solving that now, and then beyond that, doing measurement innovation to demonstrate that there are other returns on investment outside of the traditional paradigms of healthcare that are more upstream. I'm really tired of A1C levels. I'm tired, y'all. But doing that innovation is going to take time. Doing the data collection is going to take time. And if we don't take the time now, I'm really worried about 5 years from now. So let's be excited and invest in monitoring and evaluation and not end on a sour note. Thanks. Sorry.
Absolutely, and sharing our data. Be great if we had a, framework for that in California. Yes, please, go ahead.
I'm Hillary Stevens with the California Physicians Alliance. We, a little bit tangential, but getting more supports for unpaid family and other caregivers, because they're the ones who make sure the medications are taken, good sleep, nutrition, etc., that helps avoid needing to necessarily contact healthcare providers.
Wonderful. Thank you for uplifting that. I know there are lots of folks in the room who are really excited about that work, so I hope you get a chance to connect. All right, any other comments? Yes, so tomorrow morning we have a wonderful plenary about ballots to health. So now that we've gone through yet another presidential election, how are we able to affect our health outcomes at the ballot? So we want to plug that for you. It's early in the morning. Also want to say thank you so much for just participating in this workshop today. Your comments, all the notes you've written will not be in vain. We're going to be creating a report and publishing that report on our website, and we'll be sending out to all of our registered attendees as well. So be on the lookout for that. Want to remind you of a few things. Number one, the app is your friend. The app is your friend. So if you haven't downloaded the app, it'd be a great time for you to do it. And it's so easy. Here, you ready? You take this, you flip it over. There's a QR code right there. Scan it, download it, and then you can put your profile in there as well and connect with others. So be sure to download the app. A few announcements. So join us again tomorrow morning for breakfast at 8 a.m. here at the Convention Center, and then our program is going to start promptly at 8:45. Want to also share that we will be having our Spirit of ITUP networking reception starting at 5 p.m. at the Citizen Hotel, followed by dinner at 6:15. And a reminder that we are at capacity for this event, so if you haven't previously registered for it, unfortunately, we're not going to be able to take you at this time. All right, one last thing. I'm not Crispine, but there you go, wrap up. One last thing, please be sure to take a few minutes to scan this QR code and complete this evaluation. Tell us how we did, tell us what we can change, what worked, what didn't, all the good stuff, bad stuff, everything in between. Would love to hear it. We review this, and we actually do review it as a group, and we spend time digesting the data and making sure that we make adjustments based on the feedback that you give us. So please go ahead, take a few minutes to do that, and then we'll wrap up.